Next, I'm joined by Dr. Gregg Fonarow, professor of medicine at UCLA School of Medicine in Los Angeles, California. We cover Save the Obese Heart from Failure and Arrhythmias. Gregg, thanks for being here at ACCEL. Why don't you summarize some of your perceptions of how obesity affects left ventricular function or right ventricular function and arrhythmias? I think a fascinating topic these days.
So with the marked increase in the number of individuals who are in the overweight and obese category, we've really become increasingly aware of the substantial risk of developing heart failure and arrhythmias that are concomitant with having obesity. There are a number of mechanisms by which obesity can affect the heart. There can be pericardial fat deposits that are pro-inflammatory. There's changes in the ventricular myocytes, both on the left ventricle and right ventricle. And this seems to contribute to a much earlier presentation with heart failure, as well as arrhythmias such as atrial fibrillation, including acute coronary syndromes. Now, some of the mechanisms may also be related to the fact that those who are overweight and obese are at increased risk of diabetes, which in of itself is a risk factor for developing heart failure and subsequent arrhythmias. Can be a risk factor for developing acute coronary events and coronary disease earlier. There is also, however, evidence of direct effects on the myocardium, and all of this contributes then to this increased risk of developing heart failure, often decades earlier in those who are obese. And likewise, we've seen a relationship between atrial fibrillation and obesity.
We're beginning to see concern expressed nationally by political leaders and others at the obesity epidemic starting in a younger age, with concern for a very broad number of disabled people in their 40s in the future because of obesity. So what are the things that you look for first? I mean, a patient comes in, nowadays it's almost acceptable to see a BMI of 33 or 34, clearly obese, inactive, perhaps asymptomatic other than metabolic syndrome with hypertension and diabetes. What things are you looking for early on from the standpoint of cardiac risk for heart failure or arrhythmias in this group of patients who really come in, I would say, mainly for the metabolic syndrome components at that time?
Right. So I think awareness regarding this increased risk is really critically important. And often symptoms they may be having, palpitations, shortness of breath, dyspnea on exertion, are attributed to their obesity rather than the fact that heart failure may have developed or atrial fibrillation. And so really taking a proactive stance to investigate any symptoms the individual may have, as well as trying to aggressively prevent and treat obesity. What is very interesting is once an individual presents with heart failure that's overweight or obese, we really then do not have good evidence that necessarily intentional weight loss will translate to better outcomes. In contrast with atrial fibrillation, there is a number of intriguing studies where multiple risk factor intervention, lifestyle modification has been associated with reductions in atrial fibrillation recurrence. That all looks very promising. Interestingly, a recent analysis of look ahead in patients with type 2 diabetes who did achieve with intensive lifestyle modification weight loss as well as improved metabolic parameters, there did not appear to be a substantial lowering in the risk of new onset AFib. So there's a complexity in the relationship once the diseases have become established to where it really points us back to prevention in the first place, prevent the onset of all of the adverse consequences by trying to prevent individuals developing obesity in the first place.
So a patient comes to us referred many times because it's difficult to manage hypertension, for example, to a cardiologist, and it's your first attempt at trying to analyze what's going on with the heart. So our usual process is an echocardiogram. So we're looking for right ventricle size and function. We're looking for left ventricle systolic, diastolic function. What are the things that we expect to find if obesity is affecting the heart under those circumstances?
So some of the earliest manifestations would be impaired diastolic function. So that is very important to focus in on with regards to the echocardiogram. However, there will be some patients where already you see impairment in systolic function. So some of the earliest changes, an increase in LV mass, impaired diastolic function. There can be in individuals where some pulmonary hypertension is now developed, and you'll see the non-invasive parameters associated with that. In more advanced stages, you're going to see then potentially early changes in the right ventricle, if not overt evidence of tricuspid regurgitation, elevated RV pressures, and impaired systolic function on the right ventricle.
I'm thinking of the pathologic mechanism. The patient shows up with hypertension. They show up with possible sleep apnea that can concern the right side. I'm always sort of interested in the volume status of these folks because some of them show up with large right ventricles, which might at least imply that they've got an added volume load in their system. What are some of the things you can use to sort some of that out?
It can be difficult because sometimes the assessment of the neck veins in the physical exam in the very obese patient can be challenging. One of the markers we commonly use in heart failure to look at volume overload, BNP or N-terminal BNP, is actually artificially lowered in the setting of obesity and often can see levels much below what the patient's true volume status is. So it can really be a challenge. Some of the echo parameters can be helpful in this regard, as well as careful consideration of the overall exam findings and integrating all of the available information.
The other reason people are sent to us is because of dyspnea, the obese patient with dyspnea. And it's so ubiquitous now that I know some institutions have actually started dyspnea clinics. So how do you approach a patient like this? A BMI 35, hypertension, diabetes, which is complicating their life from the standpoint of significant shortness of breath with disability. I mean, how do you approach somebody like that?
So this is a real clinical challenge in the sense there are a number of potential serious conditions that may be contributing. Just to attribute these symptoms to obesity is potentially exposing the patient to substantial risk. Many of these patients can develop premature coronary artery disease. So making sure that this, in fact, is not dyspnea resulting from myocardial ischemia is critically important. As we talked about, there can be both systolic and diastolic abnormalities of the heart, so heart failure with preserved ejection fraction or heart failure with reduced ejection fraction is in the differential. As you mentioned, sleep apnea is an important consideration in these patients. So there are actually a multitude of issues that may contribute to the dyspnea in these individuals, so working them up becomes very important. So evaluation for coronary disease, echocardiography, and other testing as indicated is really critically important. And with the really substantial increased risks, often the yield from these diagnostic workups is going to be quite high, and in many cases finding something that's going to be amenable to therapy.
Now, you had mentioned some data on AFib being reversed or reduced in incidence in managed lifestyle with obesity. That was some of the studies from Australia, I think, were quite interesting in that regard. How are you approaching this? Patient with dyspnea, patient with palpitations, you do the workup, there's no serious evidence of coronary disease or serious left ventricular dysfunction. What do you do for an approach? Our normal thing is start exercising and don't eat so much. I mean, that's pretty standard advice, doesn't get anybody anywhere. How do you approach these patients?
So really, as those studies by Sanders and colleagues show, and other work shows, that why patient relationship with the physician and really conveying the health risk and trying to motivate the patient can be helpful. Really, the greatest impact come from these multidisciplinary programs that are focused on multiple aspects of trying to understand many of the barriers and the complexity that go into intentional weight loss, and that these multidisciplinary programs can be successful and use a combination of dietary modification, behavioral types of approaches, integrating supervised as well as home-based exercise, and really with that type of intensive approach, significant and sustained intentional weight loss can be achieved. And in the case of atrial fibrillation patients, certainly there was an improvement in quality of life and a reduction in documented recurrent episodes of paroxysmal atrial fibrillation.
A couple of bullet points to wrap up. What would you tell the listeners as a quick summary of some of the points you've just made?
Key to keep in mind is that obesity is a substantial independent risk factor for developing heart failure and for developing arrhythmias, including atrial fibrillation. Key approaches center on prevention of obesity in the first place. Once developed, it's hard to reverse many of the abnormalities that are associated with it. Once it has occurred, for patients with atrial fibrillation, intentional lifestyle modification and weight loss can reduce symptoms of AFib and improve quality of life. With regards to heart failure, whether intentional weight loss is associated with better outcomes, we really need prospective randomized studies.
Well, thanks again for being here. Fascinating topic, which is going to be on our doorstep much more frequently in the future, I'm sure.
Thank you.